everybody. Welcome. Oh my gosh, I didn't realize that's so loud. Welcome online to our online viewers, and welcome to everybody in the room. I'm Danielle Hicks.
And I'm Bonnie Dario.
I hope they're watching. Everybody knows I am not Danielle Hicks, but I am Danny Gasparini, and this is Dr. GUNEET WALIA. I'm going to introduce Dr. WALIA GUNEET in a few minutes, but we just wanted to welcome everyone to the room. As everyone is familiar, this is another segment of the Dario Lung Cancer Living Room Patient Education Series. Tonight we are here to learn the latest and greatest that was presented at ASCO. And for those of you that aren't familiar with the term ASCO, it's the American Association of Clinical Oncology. American Society, sorry about that, of Clinical Oncology. GUNEET's here to tell us about what she saw and learned at ASCO and how that's going to directly impact perhaps your care strategy today. So we want to make sure that it becomes relevant and isn't just sort of studies that we learned about, that we're actually going to talk about how people can practically implement some of these discoveries and what that would mean to you today. So a couple of sort of rules of engagement. If there's anybody new in the room present with us, we typically, after we introduce ourselves, oh my gosh, am I backfiring in voice? We typically go around the room and introduce ourselves. If you want to tell a short story about who you are, where you are in your journey, caregiver, patient, it's up to you. I know we have some guests from industry because this is a really important meeting, and so we want to make sure that everyone has an opportunity to chat and sort of ask questions. If you wouldn't mind looking at your cell phones to make sure they're on silent, please get up and down and get food. This is about conversation and being comfy. If I do see you fall asleep on the couch, I will call you out. No, I promise. We know somebody's gonna do it. If I fall asleep on the couch, we know we're in trouble. But so then I wanted to introduce Michelle, who's gonna be online. She's gonna be taking our online questions. Folks that are online, if you would like to introduce yourselves online, I would love nothing more, or Michelle, to say who you are and introduce yourself. As we're doing self-introductions, we've got the ALCF, Dario Lung Cancer Foundation staff in the background, and they are all out there doing great work and here to make our time wonderful, comfortable, and pleasurable. And then we have Dr. GUNEET WALIA, who is the Senior Director here at the Dario Lung Cancer Foundation, in charge of research and Director of Medical and Research. Correct? Did I get that?
Research and Medical Affairs, yes.
Research and Medical Affairs. And so we're going to jump right in. So our topic tonight, again, was updates from ASCO.
Do you want to do an around the room?
Oh yeah, let's. I did say that, didn't I? We were going to do an around the room, and I already was going to jump right into updates. So, Sally, let's start with you.
Hi, I'm Sally, and I was very high risk for lung cancer familially, plus, I hate to say it, I smoked. So I entered the International Early Lung Cancer Assessment Program, I think that's what it was called, ALCF. And I had quit smoking 30 years before. Well, it wasn't 30 years when I entered that. In 2004, I entered the test, and I had yearly low-dose CAT scans, and the point of this study was to see if low-dose CAT scans would pick up lung cancer before an X-ray would. And in my 5th year, I'd had nodules in all my lobes, but they didn't grow and they were small. And in my 5th year, one grew. And I was fortunate because it was found very early. I had my lower right lobe removed and had it nowhere else. So I knock on wood, thus far I've been fine for 7.5 years. So I'm just watched very carefully because of all the other lobes that have nodules in them. And I'm tongue-tied tonight, I'm sorry.
I'm Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013. I'm currently undergoing maintenance chemotherapy.
Then we have another mic. If anybody wants to introduce themselves and give a little bit of background.
Yeah, hi, my name is David. It's my partner, Mark. I was diagnosed at the end of March with small cell extensive lung cancer, and I'm just ending my first round of chemo and waiting to see where I go from there.
So we have some very exciting news for you. I am so excited
That's
you're here.
what I've been hearing with.
Yes.
There's a lot of exciting news. I think
Lots of exciting
everyone's
news.
gonna be-
All right.
Yes.
Everyone's just
All
going to be excited.
My name is Candace. I have non-small cell carcinoma, stage 3B. I finished treatment in November of 2015, 2014, so I'll have 2 years post-treatment this November. And I just had a CAT scan, and I have a little something going on in my upper lobe, but they're just going to recheck again in December and see if there's any changes to that.
And we should say thank you for everyone for sharing where they are, because we all learn from each other, right? So this is the whole purpose of why we're here, because I think we learn more from sharing our stories and telling each other where we're at and kind of some of the things. And that sort of blends into all the research that you found, right? It starts with the initial personal story. So we got to say thanks the whole way for doing this. Hey, Tina.
My name is Tina, and I was diagnosed November of 2010. I tested positive for EGFR, and but I did go through chemo and radiation, and I started taking Tarceva, I think, like a maintenance kind of thing, and that was 4 years ago. So far, so good.
Hi, I'm Betty Corner. It's not. Hello.
You have to turn it on.
Oh, I'm Betty Corner, and I'm coming up on 2 years since my cancer diagnosis of adenocarcinoma. I'm a never smoker and was found to have a tumor in my lung, but then two brain metastasis. And after further testing, it came out to be oligometastasis, and also EGFR positive exon 21. I had surgery in January of 2015, and right now I'm NED and just getting scans to make sure I stay stable.
Mm-hmm.
Hi, I'm Helen Del Grasso, and I was diagnosed with stage 4 lung cancer, non-small cell, the end of May. And I just started, I had radiation, and then I started in a clinical trial, which is immunotherapy and chemotherapy combination, last week at UCSF. It's a MERCK trial with the Keytruda, I hope. And so I just started that last week.
Fantastic.
Hi, I'm Rebecca, and I'm part of Helen's Hells Angel support group.
You've got two.
I know.
Two choices.
I'm Joan Fong. I was diagnosed with stage 4 lung cancer October of 2013. I'm currently on a clinical trial. I've gone through a lot of different things, from Tarceva to afatinib, radiation, chemotherapy, done it all. So in this clinical trial, I'm really glad I was with Portraza and Tagrisso combination. Tomorrow will be my start of the third cycle, and so far so good. And I'm glad that with the clinical trial we've done all these extensive tests, and I found out that I had 13 brain mets. We did brain radiation. Without those tests, I would never have known, because I didn't have any headaches or any double vision or anything like that that would start a brain MRI. So I'm really grateful that we're finding all the little buggers that seem to grow.
I'm Ron, part of Team Joan. We are coming up on 1,000 days since diagnosis. So we're pretty happy about that, because I think originally we were only expecting 200 days, and this is great. We had recently attended the Free to Breathe conference out in Minnesota, and what a difference being in the Midwest talking about lung cancer versus here. Where I'm glad I'm in California.
We are too.
I just wanted to add something to what Joan just said about the focus on individual treatment and care when you were part of a clinical trial. Because you were part of a clinical trial, you received, the kind of treatment that you received, the kind of care that you received, that you were able to find these early on. And, that's why I'm going to urge everybody to consider clinical trials at various, stages of your treatment journey, because this is the kind of benefit that you can derive from joining a clinical trial.
So question it. We're going to get to the back row, but I'm pleasantly surprised with the number of folks introducing themselves saying that they were part of a clinical trial, because I don't think we saw that introduction a couple of years ago. So two things are happening. We're getting word out that clinical trials are so important, and I'm going to congratulate the Adario Lung Cancer Foundation, because I know that was a huge push to get people the correct information about clinical trials, right? Just to get rid of the old thoughts of what clinical trials were. So, and we've got some folks in the back that are from industry. Great job. Let's keep getting people out into those clinical trials. So, Joan, a big, huge, push to clinical trials, and everybody that is inquiring and part of it and being a part of that, keep questioning your physicians if that's the right thing for you, right?
Absolutely.
So we're going to go to the back. Does anybody want to sit up front? The wine's better up front. No? Everybody's good in the back? Okay. So we'll let you.
Hi, my name is Mary. I was diagnosed in September with small cell lung and brain cancer. Had radiation and then chemo, and then another round of chemo. And now I'm on my third round of chemo. The last test showed liver and bone cancer. So yesterday, I talked to Medical One, the great people there, Dr. President, and Christina Wright, and she told me about this, and it just so happened the class was today. So having pain issues today, and that's why I have this circus outfit on. You probably can't see my Ninja Turtle pants.
You look great.
We know you're carrying the warrior spirit.
Yeah,
those
and
Ninja
here's
Turtles.
the hat that goes with it. They're loose. But thank you for hosting this. That's wonderful.
Hi, my name is Sherry. I'm speaking for my husband, who doesn't like to speak into microphones. He was diagnosed with non-small cell adenoma, lung, and he had one adeno, one squamous. Both were removed surgically because they were very small. But that oncologist waited 6 months to do a scan, and when we rescanned, it was in the chest cavity. So, chemo, 3 different kinds of chemo. He's had surgery, obviously. 3 different kinds of chemo, radiation, and then more recently there was a new little tumor right behind his esophagus. And God bless Dr. Dormady and Dr. what's his name with the cyber knife, because they took a chance and blasted it, and it's gone. But the cancer's still not gone. However, it hasn't gone to the brain, the bones, or the liver. Right. So Dr. Dormady started him on immunotherapy 2 or 3 weeks ago, Tarceva and Opdivo. So far, it's just the ugly rash that...
Puberty.
Yeah, it's like going through puberty again. And fatigue. So we'll see. It's all good. We're very happy that that's been approved, and
there's some good things that come with puberty, right? I mean, we probably shouldn't talk about it in a PG setting, but...
But thank you for being here, because we were not happy with our first oncologist, and I came here and got some very good suggestions and good advice, and we changed, and we're super happy now. Okay?
Fantastic.
That's great. Well, it's all about just putting out as many opportunities and thoughts and ideas and seeing which ones sort of fit best, right? I mean, it's all we can do is put it all out there on the table.
And constantly advocating for yourself. Because nobody else is going to ever do that, right? If you aren't satisfied with what your current doctor is saying, go to the next doctor and ask them. Inquire as much as you can till you are satisfied with your care.
I think we're going to hear a lot of the breakthroughs today that GUNEET's going to talk about from ASCO that have been patient-driven. And I don't know that we would have the area of hope and promise that we do today if it weren't for patients driving that conversation. So, I mean, we'll get into that, I know. But anyways, we've got a couple more people who have come in and want to.
Hi, I'm Lisa Goldman. I was diagnosed with stage 4 adenocarcinoma, ROS1 positive, January of 2014. And I've been stable on Xalkori for a while now, going for a PET scan tomorrow.
Thanks, Lisa. We've got, and as we're kind of shifting the microphones around, I think we have a couple more people who want to.
Who can come sit up here.
And if, again, I want to tell you, it's the God's honest truth. The wine is better on the front row. We pull out, everybody's cool? Everybody's where they want to be? Okay. So now it's my pleasure to introduce to you Dr. GUNEET WALIA. She is part of the Adario Lung Cancer Foundation team. And is, again, as I had said before, the Senior Director for Medical Affairs and Research and Medical Affairs. Present at ASCO, and I know Tina and Sally, you've sat through probably a couple of years of ASCO updates, but I think everyone's touting this year as the year of great breakthrough and promise. So absolutely. I know we say that every year, but I think this year was something. So you want to jump into ASCO and some of those updates.
Absolutely. So before we begin and go into the updates section, what exactly is ASCO? So ASCO is the American Society for Clinical Oncology, and each year this society hosts an annual meeting where up to 35,000 folks from all over the world come into Chicago, share research data, clinical trial results, and learn from each other. And in addition to these physicians, scientists, patients attend, we have advocates attending, we have members from the NCI and the NIH attending, funders, folks like us who attend this meeting, this conference. And this time there was also Vice President Biden who was in attendance at this meeting. So, I was just searching for the total number of abstracts in lung cancer that were presented at ASCO 2016, and there were 850 lung cancer focused.
Those theories, those discoveries, those let's study this.
Yes,
850.
850.
And do you know what that compares to in past? It must be a much larger number.
Usually been in the same range, but the quality of research that's presented varies every year. So, there's a lot of stuff that's happening. This is exciting times. And, this is something I usually say that if you were destined to get lung cancer, this is probably the right time to get it because of the advances, the breakthroughs, the exciting stuff that's happening in the science and the clinical medicine space. Now's the time to get lung cancer, as sad and morbid that sounds.
The disease. We don't hope on anyone.
Right, no,
but,
absolutely.
It's great to talk about promise, right? We have to push the envelope on that. So you were going to talk a little bit about sort of your 5 or 6 themes. And I think the one that's going to resonate most with everyone here tonight is going to be immunotherapy. And that's kind of where everything focused for the majority part of ASCO. So let's start there. Let's start with immunotherapy.
Absolutely. So, in terms of themes, like the theme of the meeting this year was collective wisdom and the future of patient-centered care and research. So ASCO by itself decided the theme is going to be patient-centered care, which is great, right? So in terms of themes for lung cancer, the top 5 or 6 themes that I identified, it is a 3 or 4 day meeting. We attended, I attended most of these presentations. The one thing that was clear to me was immunotherapy is here to stay, right? In the past 4 or 5 years, there's been increasing evidence that immunotherapy works. It's great, but this year's meeting, absolutely solidified this fact that immunotherapy is here to stay, and probably combinations are the way to go compared to monotherapy. And we will discuss this as we go forward. The second theme for me that emerged from this meeting was that the mainstay is going to be precision medicine. Basically identifying the right drug for the right patient at the right time. And identifying unique oncogenic drivers. We now all know lung cancer is not one disease. Lung cancer is a composition of several individual diseases. Each one of these is driven by an oncogenic marker, and we are beginning to identify new targeted treatments for each of these markers. And therefore, it is important that patients get molecular profiling. They really understand what their tumor profile is,
right?
Like what is really driving their tumor. Once you identify that, once you molecularly profile your tumor, then you identify the best treatment that is targeted specifically to your tumor.
Okay, I know you're going to go on with all these, and I have some questions on that one. But I'll save it for later, but
okay.
I want to put my notes down here for that one.
Okay, in terms of the third theme that emerged from this meeting was exciting new developments for small cell lung cancer. So not much has changed in the standard of care for small cell lung cancer in the past 3 decades, right? In 30 years, no new drugs, no new treatments, but now we are seeing very, very exciting developments with immunotherapy and also molecularly targeted therapy for small cell lung cancer that works. And we'll share more of this as we go on. Then the fourth theme that I identified was patient engagement. So there was data that was presented at this meeting that showed that the more patients are engaged and involved in their care and management of their disease, the higher outcomes you see, right? The more questions you ask, the more involved you are, the more, you're asking about molecular profiling, you're asking about clinical trials, you're asking about all those things, you're monitoring your symptoms, you're constantly in contact with your healthcare delivery team, you have better outcomes.
I think it's worth noting and stopping just for 1 second and saying that patient engagement was part of ASCO's strongest themes. That is telling you where your role is in this, that these thought leaders from around the world, and they're all coming and saying patient engagement is as important as immunotherapy, as precision medicine, and you're going to go through the last two.
Yeah.
I think we should stop and pause just and say, awesome.
Right?
Yeah.
Yeah. So in terms of the next theme that I identified, this is something very exciting scientifically and from a patient perspective also. There's this new kind of drugs that's on the horizon that are called biosimilars. And I will share what these are and how it might benefit lung cancer patients. And there's exciting data that was presented. We'll go through that. And the last theme that I identified overall was that liquid biopsies, right, compared to traditional biopsy, liquid biopsy using blood, urine, saliva is increasingly slowly but steadily being validated as a mechanism to monitor your disease and to identify when treatment resistance is emerging. So there were a lot of abstracts that focused on liquid biopsies and how you could track disease progression using liquid biopsies and not invasive traditional tissue biopsies.
So I think what we're going to try and do is we're actually going to go through each one of these themes, these 6 themes that GUNEET was talking about. But here's what I want you to do. If any point in time you have a question, you have a comment, you want to ask something specific about yourself, about the person that you're caring for, jump in, because this is meant to be a conversation, not for GUNEET and I. And Fred, you already have one.
I have a comment. When you're talking about genomic testing,
yes,
there's a catch-22.
Yes.
Especially with lung cancer.
Yes.
And that is, it's often very difficult to get enough of a sample
True.
To do any kind of significant testing.
True.
And I think a lot of us have been through that. So that's why liquid biopsy, especially in terms of actually identifying the mutation of the cancer, is so important.
Yes.
So it's actually, to me, more important that we make advances in liquid biopsies,
True.
Along with the identifying the various mutations.
I completely agree with that, and it's so important, especially the specific point that you highlighted about the paucity of tissue specimens to do the right kind of molecular testing. Go ahead.
Correct, but the other problem is that molecular testing is so vast right now. It's so that you need a tremendous amount of tissue sample to actually do it.
True. True.
And that's and that's very often impractical because of the location of the tumor.
Absolutely.
Or the or the condition of the patient.
Exactly. And that's where liquid biopsies come in. The thing is, it's still early days for liquid biopsies. We haven't reached the point where we can routinely use liquid biopsies in the clinic right now, but we are getting there. And there are several companies that are working in this space. You have Foundation Medicine that's coming out with their liquid biopsy platform. There's this company here in Redwood City, California, Guardant Health, that presented data at this meeting. They presented data on 15,000 cancer patients, and they looked at 70 different genes in 50 different kinds of cancer. And they were able to identify molecular markers in over 80% of patients. So, the precision in identifying these markers in the liquid is increasing. But the thing is, just a caveat, we aren't there yet. It's going to take some time, but we will get there.
But isn't this awesome? I mean, Fred, as a patient, you've obviously educated yourself on all of this and what's happening. And this is what this is about. I mean, think of the knowledge that we're learning from each other and the experiences. So I just applaud all of that. And I want to encourage our online viewers, if they have any questions, Michelle, you'll just jump in and say, we've got somebody that has a question, right? You'll just...
I do, but I want to say that Bonnie and Danielle signed on from vacation and said hello. They miss everybody. They said, thank you too for jumping in. You're doing such an amazing job, they can retire.
Oh, I think I forgot to tell everybody that Bonnie and Danielle are on holiday. They're actually training for Cirque du Soleil. No, I'm just kidding. Can you see Bonnie though? I mean, of everything that she's done, I just sort of see her as this hero that I could just absolutely see her flying from the high wire.
And I do want to say there are so many patients on. I mean, I want to say hi to Betsy and Janet, Rick, Mara, Nicole, Katie, Colleen, Anita, Jonathan, Lisa, Janet. Everybody's on here.
Wow. Way to go.
So I will
So
have
the goal for GUNEET and I is that they're still on in an hour and a half.
Yes.
And I will have questions, I'm sure.
Awesome.
All right. So great. So just jump in and everybody jump in. And I think you were going to ask a question. Yeah.
I just wanted to make a comment that
Ron.
the liquid biopsies are pretty amazing. I mean, we've done 3 so far.
Mm-hmm.
And the difference between the first time we took it and the third time was light years. So they're just advancing. And it helps that I think that, there's information that says that where you sample the genetics inside a single tumor might be different in the same tumor just a little bit further away. So
Absolutely.
the liquid biopsy sort of take care of that issue of diversity within the tumor.
Yeah. Now that you've brought it up, it's good that we can discuss it right now. So in terms of, the topic that you're trying to highlight here, Ron, is what is called tumor heterogeneity. So what that basically means is that, when somebody has metastatic disease, they have several tumors. Does not mean that the tumor that they have in their hand is the same exact has the same exact molecular profile as the tumor in their lung. There will be some differences within tumors and within the same tumor, like across and within. So there is intra and inter-tumor heterogeneity. So when you're biopsying a tumor, you're probably just capturing one segment of it, and the readout that you get is just from that one segment. So you aren't getting a whole picture of what's really happening across all the tumors in the body, right? And that's where the benefit of liquid biopsy comes in, because tumors shed, right? If there's a tumor here, it's shedding into the blood. Cells are sloughing off. They're moving into the bloodstream. Even when cells are dying, they are releasing components into the bloodstream, right? So at all times, you have circulating tumor cells or circulating DNA in your bloodstream. Mm-hmm. And when you take a liquid biopsy, it kind of gives you a picture in time. Like at this particular time, this is what the big picture cancer for this patient looks like. So that covers the aspects of intra and inter-tumor heterogeneity.
Well, I know we wanted to jump into immunotherapy, but so my question then is, you said that liquid biopsies are not sort of in that place that molecular testing is, and how much how much knowledge do we have with, is it because the liquid biopsy technology isn't there, or is it we don't know what to do with the information once we get it yet?
Both things.
Okay.
So the technology is there. But if we see something in a liquid biopsy, what do we validate it against, right? How do we know that what we are seeing in the liquid biopsy result is actually what's actually happening in the tissue biopsy is the same thing?
Okay.
Because what you sample in the blood is even normal cells get shed, even normal DNA is in the blood, right? So what's your comparison? What's your validation? So that's one thing. The other thing also is that, once you have all this information, there are times when you cannot do much with it, right? Because we all know lung cancer, if you consider it as a pie, there are several individual slices of this pie, right? Which are all individual molecular subtypes of disease that are each driven by a different gene, right? So we have targeted therapies for many of these molecular subtypes, like for EGFR-driven cancer, for ALK-driven cancer, for ROS1-driven cancer. But there are several other subtypes in this pie that we don't have treatments for, right? So even if the technology is there, you've identified what's happening, you might not have the best possible answer for that particular patient. Okay. So that's another thing. But one positive, exciting thing that happened recently around the same time as at ASCO was that the FDA approved the first ever liquid biopsy test for EGFR mutant lung cancer. So the first ever liquid biopsy test was approved. This is not a panel. This is not something that looks at 70 genes. This is something that only looks at EGFR mutations, the exon 19 deletion and the exon 21 substitution. It looks for these two alterations in a liquid biopsy sample, in a blood sample, and it can tell you whether or not you have these alterations. It's usually beneficial for patients who do not have enough tissue specimen or who have tumors in a site that aren't very easily accessible. But there's also this caveat that the FDA put in. They said that, if, say, suppose your liquid biopsy test result is negative, that does not mean that you absolutely do not have the mutations.
Okay.
So you should back it up with a biopsy specimen if it comes out negative. But still, it's a benefit. We are moving forward. The FDA is getting involved. There is regulation around these liquid biopsy tests that's happening. So it's a positive step in multiple different ways.
So, yes.
I'm sorry, would this work for
Betty? There you go.
Would this work for crossing the blood-brain barrier for brain tumors?
So you can identify what's happening in your entire body. So it should, I don't know if you can, so it is going to be like an average of what's happening throughout your body.
Okay.
And with the new advancements in this liquid biopsy technology, you can identify even very, very small concentrations. So, if very small concentrations of tumor cells are being shed into the blood, these technologies nowadays can pick those up. And they pick those up way before it becomes physiologically apparent, before you get a headache, before you get any other symptoms like memory loss or whatever. You can identify those changes through a liquid biopsy like Joan here did.
So I think what I'm hearing you say is we're at the point with liquid biopsies now that if a patient received, if a physician said to a patient in the past, we couldn't there wasn't enough tissue for us to get. It's now at a point where a patient could go back to that physician and say, what about those liquid
Absolutely.
biopsies? Okay, so we're at that. That's the thing to take away. We're at that point where now a physician needs to take that option very seriously because we have enough data and metrics and research that says that this could be a way for us to do some more profiling, right?
Absolutely.
Okay, so I think we're safe to move on to immunotherapies. No, you're not ready.
Okay, no, I just wanted to add one point about liquid biopsies and how this is slowly becoming a craze and how everybody's jumping onto the bandwagon. Insurance agencies are now getting on board. What I was talking about, the Guardant Health assay. So there's this one insurance company, I forget the name of which, recently said they will cover Guardant 360 liquid biopsy assay.
That's another big breakthrough.
So that's another big step, right? The FDA is coming in, we have insurance agencies coming in, willing to pay for these tests, because obviously they will benefit, right? If you identify what's happening beforehand, earlier on, they don't have to pay for complications going forward, right? So all these positive changes are happening in the space.
That feeds all into it, right?
Absolutely.
All right, so we wanted to jump into immunotherapy because I think that was, again, where most of ASCO was focused and some of the most promising and breakthroughs. And I think I heard almost the majority of the room really talk about some level of immunotherapy or some kind of drug that they've been prescribed as well. So tell us what's new there. I know there's a lot in it, so we're going to spend a little bit of the majority of the time here for a little bit.
Yeah. Before I jump into this, I just wanted to share with everybody, I wrote up most of everything that I'm going to talk about today in this handout. It's also posted on our website, so in case I miss anything, if you don't get completely what I'm trying to say, it's all in here.
And it should be right around, and if you want a copy, you should sit in the front row. Darn it, by the end of tonight, that couch is going to be filled.
Okay, so immunotherapy. So, before we go into what's happening and what was reported at ASCO, what exactly is immunotherapy? So just a small little primer on what this is. We all know we all have an immune system that's constantly, sending out small little immune cells throughout our body to scan if there's any foreign invader in our body. It could be a virus, bacteria, anything, or even a tumor, right? So these immune cells called T cells are constantly roaming our body to identify if there's an invader present. How they do that is these immune cells have several molecules on their surface, on the surface of the cell. So as they are moving, these molecules are looking for other molecules. They come in contact with other cells, the molecules connect, and they know if there's a handshake, they know, oh, no, this is a self cell. I don't have to kill it. But if it's a foreign cell, they know, oh, this doesn't belong here. I need to kill this. So what the immune cell does when it identifies an invader or a foreigner, it replicates and divides and increases in number, mounts an attack on this invader, removes it, right? So this is how the immune system works. Now what cancer does is it knows this handshake. It knows how to make that handshake. So the cancer cells have all the right molecules on their surface so that when an immune cell comes in, they do the right handshake and they get avoided, and there is immune tolerance. So the immune system just ignores them, thinks it's self, and just moves on. So it doesn't mount a response. So now the immune system has to keep checks and balances, right? It does not have to mount responses against self cells. So these checks and balances are called checkpoints. Right? So the immune system has several checkpoints. When it's mounting an attack, increasing in numbers, it has to make sure that it is doing that for the right invader, right? So these are checkpoints that cancer cells overtake. So what they do is, one of these checkpoints that is most talked about is called CTLA-4. What this checkpoint does is, it turns the immune system off, right? Cancer cells benefit. Immune systems turned off, they can replicate, grow, and divide, right? So we now have new drugs. There's one drug that has already been approved for melanoma, is now in trials for lung cancer. That's called ipilimumab or Yervoy, right? So that is an anti-CTLA-4. It prevents the immune system from shutting down, and it allows the immune system to mount an attack. So that's the first stage, right? Now, once cells are ready, cells are activated, the next stage is for these cells to replicate and divide, right? Mm-hmm. So in that stage, a new checkpoint comes in, because the immune system wants several checks and balances in place. It doesn't want random, expansion, right? So the second checkpoint is what we know as PD-1, PD-L1. So what PD-1 is, it's expressed on the surface of this immune cell. It goes about looking, it's like a lock, imagine it as a lock on the surface of the cell. It's looking for its cognate key. The key is PD-L1, which is expressed on tumor cells, right? So when PD-1 and PD-L1 bind, the handshake happens, it's ignored. Tumor is ignored, right?
No, and that's a good thing. That's what you wanted to.
No, it's not a good
bad thing.
Yeah, because tumor cells deliberately express PD-L1 to avoid attack, right? So what we want is this handshake to not happen. We want to break this handshake. So what we do is we bring in drugs that bind PD-1 or bind PD-L1 so that they can't interact, right? So that is what PD-1, PD-L1 checkpoint inhibition is. You prevent the secret handshake from happening. And if the secret handshake does not happen, the immune system replicates, divides, and mounts an attack against cancer. Right? So now I discussed two different checkpoints, the CTLA-4 and PD-1. Right now for lung cancer, we have two new therapies that were approved in 2015. Both of these two new therapies were anti-PD-1 antibodies, one of which was nivolumab, Opdivo, and the second one was pembrolizumab or Keytruda. These drugs were approved last year for squamous and non-squamous lung cancers. Great, beautiful responses, patients responding beautifully. The one thing that was seen was that only 20% of lung cancer patients responded to immunotherapies. And these approvals for these two drugs, nivolumab and pembrolizumab, were done in the second-line setting. What second-line means is when patients stop responding to first-line therapies and progress, that's when they need a second therapy, that's second-line setting. And these drugs, nivolumab and pembrolizumab, were approved in the second-line setting. Now, like I shared, patients who responded beautifully. Durable responses, many, many months and years.
Second line.
Yes, in the second line. Beautiful responses, right? So the first question that comes to mind is, if you are seeing such beautiful responses, why would you want to limit them to second line? How about move them up into front line, right? Get nivolumab and pembrolizumab into front line. So those trials were conducted and the results were presented at ASCO this year. Based on the early data that's coming out, my assessment was right now, patients should not get on nivolumab or pembrolizumab in the first-line setting outside of a clinical trial. Let me explain why. So when nivolumab and pembrolizumab were approved in the second-line setting, a drug, when it's approved, it needs to be compared against something, right? Is it improving patient benefit? Is it improving survival? In the second-line setting, the standard of care, everybody knows, is docetaxel, right? Nivolumab, pembrolizumab were compared to docetaxel. Docetaxel only has 7% response rate, so only 7% patients respond to docetaxel. These two drugs showed much better responses, got approved, right, in the second-line setting. Okay. Now consider the first-line setting. The first-line setting standard of care is platinum doublet chemotherapy, right? With these platinum doublets, we see response rates in the range of, I would say, 25 to 35%. That's already established. That's what the standard of care right now is. So if we are bringing in new agents into the frontline setting, we want these agents to do better than what we have right now, right? So we want them to perform better. In these trials, that nivolumab was tested as monotherapy or pembrolizumab was tested as monotherapy, the response rates were in the range of 25 to 30%. So it's not like a huge change or, it's very similar to what's seen in the second-line setting. Interestingly, though, if these patients in the frontline setting were tested for PD-L1, if their tumors had PD-L1, which is the key protein, they had that protein, the responses went way up.
As a frontline monotherapy.
Frontline monotherapy, if your tumor expresses PD-L1, you will respond beautifully. So if you were to take immunotherapy in the frontline setting, you have to have PD-L1 testing done. Make sure your tumors have PD-L1 and only then get on these drugs and in clinical trials. So that's the data that came out of ASCO this year, right? So what about patients who do not have PD-L1? In the frontline setting, I don't have PD-L1. I want these immunotherapy drugs. What do I do? So to address that question, there were also these other set of clinical trials that were conducted, and the results were presented at ASCO, combining these immunotherapy drugs with chemotherapy drugs, right? Okay. The current standard of care, the platinum doublets, combining them. Now, what's the rationale? Why would we want to do this? The rationale for these combinations is that when chemotherapy kills cells, right? Cells die, whatever's inside the cell gets released, right? When these individual components from inside the cell gets released, they get exposed to the immune system. The immune system recognizes this is not normal, right? So the immune system mounts an attack. So if you combine these two, you are killing cells, you're releasing antigens. These antigens are basically materials that allow the immune system to recognize and mount an attack. You combine them with immunotherapy, you get tumor responses. Does that make sense?
Is everyone...
Chemotherapy releases
we've got
antigens.
kind of going,
okay,
not quite sure. So, and we have a question,
Yes, please.
Karen.
Oh, yes, Dr. Walia, I'm wondering if you have cancer cells that have been shown to be immune to the platinum chemotherapy, would this therapy,
Yes.
immunotherapy, still work?
Absolutely, in the second line setting. So you've already been on chemotherapy, your disease is progressing, is not responding to first line chemotherapy, you progress, and in the second line setting, nivolumab and pembrolizumab are approved, you can get on them. For nivolumab, you do not need testing for PD-L1. For pembrolizumab, your doctor will test if your tumors express PD-L1. If they do, you will get on PD-L1. There are not many differences between these two drugs. One of the top differences is that nivolumab is given every 2 weeks. Pembrolizumab is given every 3 weeks. And when you go in for a pembro infusion, you have to sit there for 30 minutes. When you go in for a nivo infusion, you have to sit there for 60 minutes. Like, those are the differences, the major differences. Otherwise, there aren't many differences in the impact on the tumor, impact on tumor regression and shrinkage.
So let me see if I'm relaying this correctly in what you're saying.
Yeah.
So, because we want to make sure that, so if someone has already been on a chemotherapy,
yeah,
and then the immunotherapy may be a good choice for your second line.
Yes.
But someone who's newly diagnosed and you have
does
not
have
picked,
marker.
right, and you've not picked your choice of or your chemo direction,
Yes.
right? This may be either by combination or by combination,
yeah,
the right question or suggestion for the physician and for your particular case.
I will just go one step upstream from that. If somebody is newly diagnosed, the first step that we strongly recommend is to get molecular testing.
Right.
Identify if you have any of these molecular markers like EGFR, ALK, ROS1, MET. There are several different markers that you should first get tested for. You can get Foundation 1 testing. There are several other tests in the market that you can get to identify if you have a molecular marker that can be targeted. If you do not, and chemotherapy is your option, do inquire about clinical trials. Clinical trials that look at combinations of chemotherapy with immunotherapy, or combinations, or even monotherapy, but only in clinical trials, not outside of a clinical trial setting. So I
think we had one more
there was
question.
Another question.
Yeah.
Yes.
No. Yeah.
What is Tarceva? How is that working off vivo? I don't understand that.
So we'll get to that in a few minutes. I'll get to that for sure. So this initial data from combinations of immunotherapy with chemotherapy was presented at ASCO. Very early data. We should know for sure by fall this year when the trials are completed and all the data analysis happens. But it looks like in combination with chemotherapy, responses are better.
Okay.
Right? And responses are even better if you have PD-L1.
Okay.
So, this is emerging data that was presented at ASCO.
And then I think we're going to also talk about combinations with 2 other forms.
Yes.
Okay.
Yes. So, this is one combination that I discussed. There is also combination with radiation therapy that's being tested. There are combinations with targeted therapies that are being tested. So why radiation therapy? With radiation therapy, there's this very interesting phenomenon that occurs that's called abscopal effect. So when somebody gets radiation to a particular lesion, it's been observed for several years, it's been seen that other lesions and other sites also shrink. And we don't completely understand why that happens, right? So that's the abscopal effect that's seen with radiation therapy. Now, there are clinical trials that are underway that are combining radiation therapy with immunotherapy to see if, because radiation therapy also releases these antigens. Cells die, antigens released, you bring in immunotherapy, mount an immune response, and wipe out everything, right? So that's why combination with immunotherapy is radiation therapy is being tested. The other combination that's being tested is with targeted therapies, and the question that you asked about EGFR, right? So what exactly is EGFR? EGFR is a particular molecular driver. It's an oncogene, or it's an altered, abnormally functioning gene that drives cancer where it's seen, right? So there can be several different alterations, there can be several different mutations, but when that happens in a cell, a normal cell gets an EGFR mutation, it goes on this path that it becomes cancer, right? And when a cell has EGFR mutation, we know we can target it with specific drugs. Mm-hmm. These drugs specifically go and affect EGFR. and therefore Tarceva. Tarceva is a specific targeted therapy for EGFR-altered lung cancers. We have several such agents. First-generation inhibitors include Tarceva, afatinib, gefitinib. Then there are second-generation inhibitors. We also now have third-generation inhibitors that are now being approved and are approved for EGFR-directed cancers. There was data that was presented at ASCO that showed combinations of targeted therapies with immunotherapy. And something very interesting was presented. So what was seen was that when you combine immunotherapy with a targeted drug like Tarceva, like Tagrisso, like all of these different targeted drugs, what happens is that you see infiltration into the tumor microenvironment of immune cells. So what is the tumor microenvironment? This is, the tumor sits in a milieu or in a neighborhood of multiple things, right? There are blood vessels, there are immune cells, there are fibroblasts, there are multiple different kinds of cells that in some way communicate back and forth with the tumor. And there is evidence to prove that this communication between the tumor and its microenvironment determines whether cancer will progress, whether cancer will respond to treatment or not, right? So the tumor microenvironment is very critical, right? So when you want patients to respond to immunotherapy, you want immune cells surrounding the tumor. You want immune cells to infiltrate the tumor microenvironment, right? And this data that came out at ASCO showed that with targeted therapies combined with immunotherapy, you see immune cell infiltration into the microenvironment, right? Which is perfect. Why? Because if you have immune cells surrounding the tumor and you are priming these immune cells with immunotherapy, they are ready to mount an attack, kill the tumor. Right?
So these cells are really smart, right?
Right. Yeah.
And
we are smarter.
Well,
right?
I was remiss in saying that Dr. Walia is a PhD in molecular biophysics. So that's where she comes from in knowing, and you are smarter than these cells, and you are a hero in being able to tell us and bring all of this knowledge to us. And I was remiss in talking about how amazing you are and your background and your experience with oncology and cancer.
Thank you. So in terms of, that's
Do you have
why
a question?
combinations
I think Michelle has a question
Yeah.
online.
We have a couple questions.
Okay, should we break here and go into them?
Yeah.
So
Sounds
one
good.
of them, and I don't know if it was at ASCO, but someone's asking, what about the CAR T therapies or stem cell-based therapies? Can you talk about the abstract at ASCO and discuss the approach?
Sure. Okay, we can do it right now. So what is CAR T? So this is another very exciting immunotherapeutic approach, CAR, C-A-R-T. CAR stands for chimeric antigen receptor. T cell is an immune cell. So CAR T cell therapy. Basically, it has been seen for liquid tumors, not solid tumors. It's increasingly being seen for solid tumors, but it's been established almost for lymphomas and leukemias. What they do is they isolate immune cells from your bloodstream. They take these immune cells to the lab. They engineer these immune cells in a fashion that they can recognize cancer, right? They put in these very interesting receptors on these immune cells, on the surface of these immune cells, and they put them back into the bloodstream. So these are engineered T cells
that are smarter,
and put back into your bloodstream. When they enter your body again, because they are trained to recognize cancer, they instantly go right after cancer and kill it. And we've seen beautiful, durable responses for leukemias and lymphomas, both in adult and pediatric cancers. Now this technology, this CAR T cell technology, is being adapted for solid tumors, and there is some very early data that's being presented for lung cancers also, using the same technology, using engineering of these immune cells in the lab, and then putting them back into the body.
What phase of clinical trials would they be in?
It's still phase 1, 2. Yeah, it's still early
But
on.
something to watch.
Yes, something definitely to watch out for.
Okay.
Yeah.
thank you online for bringing that question up forward.
Well, and I want to tell you that all the patients are saying you're doing such a great job of making it patient-friendly, understanding. They all said they've never understood it like they do tonight.
Oh,
so
thank you.
She's uber smart, isn't she?
Okay, let's not talk about me. Yes, Lisa.
Thanks, Lisa.
So I don't know if I'm in the minority, but I didn't really have solid tumors. I had what they call ground glass opacities, or I've heard it termed differently, but it's this like cloudiness that shows up on my scans, not solid tumors so much.
Yeah.
Does that affect the immunotherapy or any of the things you're talking about? It's the same. Okay, because I just.
And when I say solid tumor, I don't, it's used very loosely, and I should probably apologize for that. Solid tumors is anything that's not in your bloodstream. That's not a leukemia or a lymphoma, So solid tumor, that's what I mean by a solid tumor. And irrespective of what you have, the ground glass lesions, immunotherapy will work. Because the immune system is throughout, right? And once it's primed, once it's activated, once it's primed, it will go after what is not self. And cancer is not self. However it is, whatever form, it will go after it.
Does that help, Lisa? Yes. Good. Awesome.
Okay. Yes.
Yep. Fred.
Before we get too far, I'd like to just clarify what you said about immunotherapy versus chemotherapy and the combinations.
Yes.
What you're saying is that as a second line, immunotherapy is fine. It's been approved, et cetera. But as a first-line therapy, it should only be used in a clinical trial at this point. Is that correct?
Yes, and especially if you were going to look at only monotherapies, not combinations, early data suggests it's better if you have PD-L1. If your tumors express PD-L1, that's when you get mono. In terms of combinations with chemotherapy, it doesn't really matter. PD-L1 expression doesn't really matter, but there are beautiful responses but it's still early data. I'm a scientist, so I caution people before they derive extensive conclusions from early data. What I mean by early data is these trials have been conducted in few patients. These are small trials, and these aren't conclusions. They will reach conclusions, like I said, in fall of this year, when we will know for sure this way or that. But right now, the early signals are pointing towards benefit.
Okay, so if you're on chemotherapy as a first line, you should stay on it, but not consider a combination with immunotherapy, correct?
You can. But if things are working beautifully for you, I would recommend not changing status quo at this point. But, I'm not a doctor.
I understand.
But it's worth a conversation, right?
With your doctor.
Okay, so,
absolutely.
Yeah, I just want to, because this is kind of a vague area right now. So if you're already on chemotherapy, it's possible from what you said to then, try to incorporate immunotherapy to enhance the effect.
Yes.
And then you wouldn't rule that out. Is that what you're saying?
No. Definitely not. Do not rule that out. Have a discussion with your doctor and see what they say, what they suggest based on how long you've been responding to chemotherapy. And you said you were on maintenance.
Right.
So like pembrolizumab, the compound from Merck, was tested in this particular trial in 3 different combinations of platinum doublets. And what was shown in the trial, early results again, was that depending on the specific platinum doublet you had, your response varied. Right? So if you were on carboplatin paclitaxel, your response was lesser. But if you were on carboplatin pemetrexed, which is Alimta, you had better responses.
Yeah.
So even the specific kind of immunotherapy you were on impacts the response that you will get with immunotherapy.
Right.
Early data.
Yeah, because you don't want to go on immunotherapy at the very beginning, because what's going to happen is you're going to get a false positive. In other words, the tumors will increase in size.
Oh, so what you're talking about is pseudo-progression.
Exactly. And so you can't tell whether you're actually progressing or the immune system is causing these tumors to increase in size because they're being invaded by immune cells.
Right. That's a very interesting phenomena that you bring up, and let's discuss it right now. So what is pseudo-progression? So when patients go on immunotherapy, this is, broad general concept. Immunotherapies are being used for melanoma, lung cancer, renal cancers, multiple different cancers. So this applies across. When patients go on immunotherapy, immune system gets primed, immune system infiltrates into the tumor microenvironment. So on a scan, it appears like your tumor volume increased, right? But in reality, there hasn't been an increase in your tumor size. It's just that there are several immune cells that are infiltrating and are getting ready to prime an attack, right? So on scan, it seems like your disease is progressing, and it actually isn't, and therefore it's called pseudoprogression. So pseudoprogression is seen very often in melanoma and in renal cancers. It was originally believed that even lung cancers have pseudoprogression. There is very early data, again presented at ASCO, that says lung cancers probably do not have the same level of pseudoprogression as is seen in melanoma or as is seen in other cancers. So when you see progression on immunotherapy in a lung cancer patient, it might actually be real progression. And there was a paper that was presented by a team at Johns Hopkins that showed in 71 patients that went on. So what happens is, I will backtrack. You see pseudoprogression, or you see progression, right? You're on immunotherapy, you see the sizes of your tumors are increasing on a scan, or you see progression in some form or fashion, right? If you were a melanoma patient, you would say, oh, it is just pseudoprogression, you would continue, right? In lung cancer, there are things that you need to do. You need to probably stop treatment and assess what's truly happening.
Right.
Patients are reluctant to stop treatment because they think, oh, it's just pseudoprogression and it's not really something I should be stopping treatment for. But this is where you need to have a proper discussion with your physician, because in lung cancers, we don't completely understand if pseudoprogression happens or not, and if it does, to what extent. Right? So the Johns Hopkins study that I was sharing, 71 patients, lung cancer on immunotherapy, anti-PD-1 therapy, expressed, their disease progressed on immunotherapy, and they continued treatment. Despite progression, they continued treatment. This is called TPP, or treatment past progression, right? So these 71 patients that went on TPP, only 5% of these patients had tumor shrinkage. Does that kind of make sense? So if you continue treatment despite progression, it's not like you're going to control the cancer. It's not like the treatment is working. So you need to stop and assess what truly is happening. If the patient's doing well clinically, if the progression isn't very severe and rapid, you can probably try and continue for some time. But you need to assess at that time. You need to understand what all symptoms you have the discussion with your doctor, because if you continue on treatment inappropriately, it can be fatal. So we have to understand these caveats when you are playing with the immune system, right? Because we don't completely understand how the immune system works. And if you see progression, if things are happening and you don't report this to your doctor, it can be extremely dangerous. So when you're on immunotherapies, it's very important that you constantly communicate with your healthcare delivery team and share the kinds of symptoms that you're experiencing. Because the symptoms that you see when you are on immunotherapy are very different from what you see when you're on targeted therapy, right? Because you see all kinds of immune things happening. Right? So those need to be tracked, and there are, you can manage these side effects. It's not like, if you experience side effects, that's the end of immunotherapy for you. No. There are ways in which you can manage these side effects. You can go on steroids, and if you have to halt treatment, go on steroids and come back on treatment, it does not change treatment efficacy by a large extent. So it is important to manage your side effects when you are on immunotherapy and to have that conversation with your doctor.
So I want to do one thing. I want to do a time check, because we are probably about 50 minutes for the session, and I know you have 4 additional themes that you want to talk about, but this seems to be really important, and we knew that immunotherapy was going to be a really big conversation point that everybody wanted to talk about. I've got 2 questions that came in, and one is really important to address, because I still think there is a lot of misnomer about molecular testing.
Yeah.
And the question was, is molecular testing not standard or mandatory after diagnosis? I mean, how can it be? I think basically what we're saying is, how can this not be standard? And yet I think we still see it not being standard.
Yeah, and that is the unfortunate part that I struggle with. I just don't get it. It's part of the NCCN guidelines. It's part of most of all guidelines that are there for doctors to treat patients, right? Most of these guidelines say when you have a newly diagnosed lung cancer patient, test them for EGFR, ALK, and now ROS1. You have to. But it is unfortunate that these medical oncologists in the community setting are not testing for these molecular markers and are immediately putting patients on chemotherapy.
Right.
And these are patients who could have potentially benefited from targeted therapy and responded beautifully, durable responses.
So the answer is, while it's not a mandatory, it is part of the guidelines. So,
Yes.
I mean, it's not a matter of being legal or illegal. It's a matter of it's part of the guidelines. It's proven that should be standard of care, but yet we still have some patients falling through the cracks and needing to fight for this standard of care.
Second
Second question.
Why advocating for your own care.
Second question is, are there any trials yet with a TKI and immunotherapy combination?
Yes, there are. And I think you here are on that trial, right? There are 2 patients right here in our living room today who run a clinical trial that's looking at a combination of a targeted therapy with immunotherapy. There is PD-1 combinations with EGFR. There are combinations with CTLA-4. So there are several clinical trials, and whoever you are, I urge you strongly to please go see your doctor, talk to your doctor, and ask about these clinical trials.
And in our notes, we talked about there were combinations that we talked about with first line, combinations with other checkpoints. We talked about combinations with agonists.
Yeah.
Correct. We talked about combinations with chemo and radiation, now targeted therapies, and then the pseudo
progression.
Right. So did we leave anything out for with immunotherapy?
The one thing that I did not discuss yet was these combinations we discussed with chemo, radiation, targeted therapies. There are also combinations with other immunotherapeutic agents that are being tested, right? So nivolumab, which is already approved, with CTLA-4. Remember I talked about 2 different checkpoints, CTLA-4 and PD-1. There are now combinations in lung cancer that are looking at combination of anti-CTLA-4 with anti-PD-1. The rationale for that is very simple. See, why? Because CTLA-4 works in the first step when the immune system is getting ready to mount an attack. PD-1 moves in the effector, it works in the effector phase. So there's one inhibitor that works in the activation phase, and there's another inhibitor that works in the effector phase. You combine them, you get rapid responses because you get immediate activation, and you get durable responses because it lasts longer, right? So therefore, that's the rationale for combining CTLA-4 with PD-1. And these are being tested in patients in lung cancer in the frontline setting. Interesting responses being seen. So that's one. So there are other combinations we can go into, but for the benefit of time, I think we should move forward.
And I want to tell everyone that the questions can continue even after we are offline, and also conversations can continue. But I want to keep us on track and talk about all the themes.
Yeah.
So I'm going to put you on the spot. What is the one thing that you're going to say to our patients tonight that say, if you haven't had a conversation with your physician about immunotherapies, what are they going to take into their physician office tomorrow morning?
So if you aren't on any immunotherapy drug right now,
or haven't had the conversation,
start that conversation.
Okay.
Have that discussion. Understand your potential for responding to an immunotherapy drug. So it's interesting you asked me that question, Danny, because how do I, as an individual patient, know that I will respond to immunotherapy, right? So are there any kind of markers that can identify whether I will respond to immunotherapy or not? So there is one marker right now that's being used that's called PD-L1. So what we do is we test tumors. We see if tumors are expressing PD-L1. If they are, great. We know that this patient will most likely mount a response. The problem is PD-L1 is not the best biomarker. There are several reasons why. PD-L1 expression, sometimes it is being expressed, sometimes there is no expression. So it varies over time. It varies in space, right? So there are temporal and spatial heterogeneity, right? So PD-L1 is not consistent in its expression. So you can't be absolutely sure that if you don't have PD-L1 today, you absolutely don't have it. And also, if say suppose
at that time be retested?
Probably. And the other thing is that even if say suppose you had PD-L1, there are patients who've responded beautifully without having PD-L1 in their tumors. Okay. So it's not a reliable biomarker. So what the field right now needs is better biomarkers, right? And what was presented at ASCO was new research, new exciting research in identifying these new biomarkers. And what could potentially be these biomarkers? I talked about tumor cells infiltrating into the microenvironment. That is a biomarker. So if your tumor microenvironment has these immune cells, you are more likely to respond. And there are ways in which you can check for this. There are ways in which you can see if your tumor is hot. When we say hot tumor, it means tumors that have immune cells in the tumor, tumors that are inflamed because there's lots of immune cells entering.
Okay.
So a hot tumor is more likely to respond to immunotherapy. And you can find that out.
Right. And then obviously, I mean, we're going to always point all of our patients to Michelle and Danielle to have an extended conversation about immunotherapy and when it's the right time to start speaking with their physician and help navigate that conversation and where to start and all of that. Yeah.
Yes,
Well, good. We've got questions. Let's go.
Yes, please.
So on the topic of the hot tumor, you said there's ways to find out if your tumor is inflamed.
Yes.
Is that also genetic testing, or what kind of testing is that?
It is testing, but it's called mRNA sequencing. So it's not widely available, but you can, it is being done. It is still early days. It is still in trials. It is still early days in the lab and the clinic, slowly moving into the clinic. But what is being done is these immune cells that I was talking about, T cells, and there's another kind of immune cell that's called B cell, right? So you test the gene signatures for T cells and B cells, and you see if these genes are elevated or not. And you will know if these cells are within the microenvironment or not. If they are, your tumor is inflamed, it is a hot tumor that is more likely to respond.
And I'm sorry, what kind of testing was it called?
mRNA sequencing. NA. It is in the notes. Yes, yeah, that's okay. Yes.
We need to pass the microphone back, Joe. Oh, thanks, Garrett.
Given all of the issues with PD-L1 testing, there was some data released on tumor mutational burden as a biomarker and possibly a way to predict patient benefit to immunotherapy.
Yes.
Can you talk to us a little bit about that, please?
Absolutely, absolutely. So this is a very, very interesting point, and it was presented at last year's ASCO.
Do you want to repeat it really quick?
Yeah,
just in case some of the viewers didn't hear it.
Absolutely. So what the question was asked was about mutational burden as being a potential biomarker. So what do we mean by mutational burden? Mutational burden means how many mutations per segment of genome do you have? As in basically, how many mutations does your tumor have, right? So greater the number of mutations, higher your mutational load, right? And there's emerging data that says that if you have a high mutational load, there is a higher likelihood that you will respond to immunotherapy, which makes very much logical sense. I'll explain why. So when you have lots of mutations in your tumor, there are many things that are abnormal, right?
Right.
When things are that abnormal, these present relatively easily to the immune system, right? The immune system can relatively easily recognize that something's not right, this is not self, this is foreign, right? More mutations, more abnormalities, easier recognition by the immune system. Right? So if you have a higher mutational burden, you have a higher mutational load, you are more likely to respond. So does that mean you should have high mutations? Is that a good thing? I don't know about that. It's probably not a good thing. How do you get high mutations? Exposure to carcinogens, exposure to cigarette smoking. You get exposure to carcinogens, mutations in your tumors increase, you have a higher mutational burden. So patients who have small cell lung cancer, patients who have squamous cancer, patients who have KRAS alterations, patients who have BRAF alterations in their tumors, all have higher mutational loads. And all of these patients are better candidates for immunotherapy. Lower mutational burdens are seen in patients with targeted therapies like EGFR, ALK, ROS1, etc. These tumors are not as highly mutated, and therefore their responses to immunotherapy are lower, lesser, and therefore they need to consider combinations.
Okay.
Does that answer your question? Awesome.
So
we had another question.
Oh, we did. Did we? Oh, go ahead.
Just quickly, use our mics.
Those darn mics.
All of these benefits and alternative therapies need to be raised at the stage of diagnosis. Because once you've gone through chemotherapy and radiation, you no longer have these choices available to you. You're pretty much just being scanned every 6 months, which is the standard of care, until, if you're unlucky, until your cancer reoccurs.
Well, yes and no. So no in the sense that even if you progress on first, second, third lines of therapy, immunotherapy will always be an option. Immunotherapy is always an option.
As a combination.
Or even individually. Like in the second line setting, if you progressed on chemotherapies in the first line, right, your disease is, you were on chemotherapy in the first line setting, say suppose you were diagnosed, you went on chemotherapy, you responded to chemotherapy for some time, your disease progressed after that. Now you need a second line of therapy, right? In the second line, you can immediately access immunotherapy. It is approved. You don't even have to go through a clinical trial. You can directly ask your doctor for nivolumab or pembrolizumab. If, say, suppose it's further down the lines of therapy, you can still access immunotherapy. That option is never closed.
So to clarify, it was when first line therapies were discussed, immunotherapy is not showing greater promise as a standalone in first line, but showing promise with combination of targeted therapies in first line.
And in clinical trials. I cannot underline that more. It is still in clinical trials. It has not been approved in the first line.
Okay.
What is approved in the first line is chemotherapy.
Right.
So if you want access to immunotherapy, you have to ask about clinical trials.
Okay. Okay, is that?
Yes, Ron.
If you progressed after your first line, the cancer's progressed as well. So you should retest. Like if you have EGFR, you want to know if it's mutated to T790M, because then you have some targeted therapy you can get. So you should always retest, I think, is the standard of care now.
I wasn't tested for anything other than EGFR, and my oncologist refused to test me for the other three.
With all due respect, I would say change your oncologist.
But now it's too late. You know what I'm saying?
It's never too late.
There's nothing to test now.
Well, so that's
so you were NED, which is great.
Pardon?
You were NED. You have no evidence of disease, which is great.
Not at this time, But I'm just saying.
Which is fantastic, right? But let's discuss this offline. You and I have a conversation.
And I want to go back to when you were talking about the testing for PD-L1. Is that a blood test, or is that it's a blood test, not a biopsy test? Okay.
Yes. There are new tests that will test your blood, but the original test is a tissue biopsy.
Okay.
Yeah.
Okay.
Yeah.
I think we have one more question, and I think we want to move on to one of the other themes.
Okay.
Of ASCO.
Just quickly, when let's say you have two different sites of cancer, and you're talking about the micro communication of the cancer cells, are they exchanging DNA, genetic material that makes two different sites mutate differently? Is that how you get two different sites with two types of mutations, or?
So you're asking two different questions. So in terms of having two different sites, so cancer always most times initiates in one site, right? It progresses and grows and divides and becomes bigger. While it's doing that, there are cells that will slough off, fall off from this growing tumor, enter your bloodstream, right? And reach a new location where conditions are suitable, and they will establish a new tumor. And they will grow in this new location. So that's how metastases happens, right? Cancer cells spread through your bloodstream, grow in new sites. About cancers being different from the primary site, what happens is along the way, cancers continue to mutate, right? Cancers continue, if you're being exposed to a carcinogen like, say, suppose cigarette smoking, you're constantly exposing these cancer cells and your normal cells, and there will be exponential rates of mutation that is happening. So when the cell that sloughs off from the primary tumor enters the bloodstream and goes to a new location, it is also undergoing mutations along the way. And this cell is probably already different from the initiating cell in the primary site, right? So along this way, it has acquired mutations and it is further changing When I say mutations, it's further constantly changing. So therefore, it's very likely that what you see in the primary is different from what you see in the metastatic site. Does that answer your question?
Yeah, and when it's changing, is it changing because of this microcommunication, or I'm just trying to figure out how it gets
the change is mostly because of constant new mutations being happening.
And do we know why those constant new mutations happen?
Yeah, we do to some extent. Those mutations happen when you're exposed to carcinogens. Mutations happen in response to treatment, right? A cancer cell is very smart. You know, it wants to grow, it wants to divide, it wants to take over your body. So when you put treatment pressure on it, imagine something like you're putting pressure, right? It will try to move out from this way or that way. It will try to identify a bypass. And that bypass is a new mutation. And therefore, when we say somebody who has EGFR progresses on therapy, like Tarceva or whatever else, when they progress because this cancer has developed a new mutation under that treatment pressure.
Reactivated itself.
Yeah, it's like I'm going to find a new way to divide. So
we've talked a lot about targeted therapies, right? So I think it's a great segue into precision medicine, actually, because immunotherapy really can actually be considered part of this whole precision medicine conversation.
Absolutely.
You guys probably had a burning question about immunotherapy, didn't you? And I can't move on unless, because I see your cute smiling face back there wanting to ask this question.
Thanks, Danny. My question is, if you have metabolic suppression, do you recommend starting immunotherapy, or would you wait until there was progression?
What does metabolic suppression exactly mean? Like, in what context are you asking me that? Is that, if you are on targeted therapy already and things are at a nadir, like everything's working beautifully?
Yes.
So your question is, when everything's working beautifully, should you be considering adding immunotherapy at that stage?
Yes.
So from my non-doctor point of view, I would say probably not. But it is important for you to have that discussion with your doctor and to consider options like liquid biopsies to continuously monitor what's happening in your cancer, because there are times when symptoms are not physiologically apparent. You don't know if cancer is really progressing. So if you can get a liquid biopsy, and that's where the huge benefit for liquid biopsies sits, right? If you can find out what's happening, if your cancer is progressing, you can do something to change the status quo. But if it's responding right now, I don't know, I probably wouldn't change things, but keep that in my back pocket. Always know that I have something I can go to once this stops working.
You start the conversation in advance, you're prepared when the day comes that you need to start talking about other kinds of combinations and second lines and third lines and things like that, right?
And clinical trials.
And the liquid biopsy I'm hearing is sort of that place to find out that magic PD-L1.
Progressively. Probably not that conclusively at this stage.
Okay.
But yes, progressively.
In further stages.
Yes.
Right? Okay.
Yes.
All right. So we're going to move on now to our precision medicine. I'm going to sort of give us a time check that we've got about 30 minutes to talk about
a lot of stuff.
I know, the next three themes, because we kind of hit the final one already. So let's move on.
So in terms of precision medicine, what we talked about was immunotherapy in patients who probably do not have an oncogenic driver at this point. Patients who do not have EGFR, ALK, ROS1 mutations. Now let's talk about patients who do have these alterations, who do have EGFR, ALK, or ROS1, or any of these other mutations. There was a lot of data that was presented at ASCO for these patients also. So let's start with EGFR. We know that when patients who have EGFR disease progress on therapy, usually the disease travels to the brain, and there is a particular kind of development that's seen in EGFR positive patients, which is called leptomeningeal disease. What that means is that the disease has progressed, the disease has gone into the brain and has spread in the membranes of the brain, which are called meninges, and the spinal fluid. Right? So that's where the disease is spread. Leptomeningeal disease is a serious complication of advanced lung cancer and doesn't really have a lot many treatment options at this point. At ASCO, however, there were 2 new agents that were presented that show beautiful responses in patients that have leptomeningeal disease. One of these is Tagrisso, osimertinib, This data came out of a trial that was conducted in Asia. And what they saw was that Tagrisso, or osimertinib, this new compound, which is approved here in the United States for second-line setting, crosses the blood-brain barrier and has impact on leptomeningeal disease. And you can see changes even on scans. So talking about the blood-brain barrier, that's something that we all need to understand. It's a very interesting thing. There's a barrier that prevents things from very easily entering into our brain. The brain's our CPU, right? We don't want it to like go bonkers. We want to protect it, right? So there's a barrier that prevents this from happening. And what that barrier ends up doing also is that when you get a systemic treatment, when you get a drug, the concentrations of the drug that are actually going into your brain are lower. So if, say, suppose, as an example, you're getting 200 mg of whatever treatment that you are on, right? The actual amount of what is entering your brain would probably be 30 to 50 mg, right? So if you were to have, and that's a perfect place for cancer cells to go and hide, because there isn't enough inhibitor, there isn't enough drug that's reaching there.
It's a safe place to hide.
It's a safe place. So that's why most lung cancers with EGFR or ALK mutations progress in the brain, because the current treatments that we have do not cross the blood-brain barrier, so the concentration in the brain is very less. But now we are designing new drugs that can very easily cross the blood-brain barrier and have almost same concentrations as in your blood, in the brain, right? And those two new drugs for EGFR were presented at ASCO. There are details in this. We don't have time to go over all of this, so I'll leave it there. Similarly for ALK-positive cancer, when it progresses, again goes into the brain.
Right.
We have several new compounds that cross the blood-brain barrier, have activity against brain mets. Beautiful activity, durable
So that would be
responses.
a post-drug. So you've got brain mets that exist.
Mhm.
This is a breakthrough, a drug that could be used once the cancer's already progressed.
Yes. Okay. So now when you know that the first-line treatments that are currently approved, that are currently standard of care, do not cross the blood-brain barrier, what the first question that would come to anybody's mind is, should I then start with the drugs that actually cross the blood-brain barrier?
So it prevents it.
Yeah, just prevents it from happening in the first place. And those trials are already happening right now to identify whether we can do that or not. And I'll give one example. The example I'm going to present is of the drug called alectinib, or Alecensa. It was approved in the United States last year for ALK-positive disease in the second-line setting. There is now a global trial. The results of the Japanese arm were presented at ASCO that shows that when you give alectinib and you give crizotinib, which is the current standard of care, patients respond better to alectinib, durable responses, less side effects. I think the progression-free survival limit for this trial was not even reached, and in crizotinib, patients progressed in 10 months. So that shows you the benefit that these kinds of drugs can potentially have if given in the frontline setting. But it's still early days, small trials, no final conclusions reached. It's just an option that we all need to know about. And these trials are happening. This work is ongoing. And if somebody's interested, we can participate. We can participate in these
another
trials.
huge area of promise, right? The
Yes.
blood-brain barrier.
Yes, yes. And crossing that and designing drugs specifically so that they can cross the barrier.
Right. Yeah. Right. So, and did you want to talk about the 3 new agents, or do we want to move sort of right on to patient engagement? Because I think that's going to be a big conversation point.
So yeah, because you're going to skip this, I'm just going to reference my handout, my 19-page handout. Please go through this. It has details on all of these new drugs and the specific results from the clinical trials that were presented at ASCO. If you have questions, please email me. My first name, GUNEET@lungcancerfoundation.org. I'd be more than happy to help.
And we'll make sure everybody gets that, and we'll make sure that everyone sees it online as well.
Yeah.
I've got 2 questions that are very, very specific, but what I want to do is move into the patient engagement section, talk about those themes at ASCO, and then if I can ask these questions specifically because we have time, we will. If not, we'll get those answers online.
Okay.
Okay?
Sounds
Does that
great.
sound good?
Yeah. So in terms of patient engagement, there was this, I've been attending ASCO for several years, and for the first time, I saw an abstract that talked about patient engagement and a mobile app being given oral abstract status, like oral presentation status, so that these investigators were given stage time to discuss this abstract. And it has never happened. For me, it was unprecedented that somebody who was discussing patient engagement, was discussing mobile apps for patients, was given stage time. And there was, it was for good reason. So I'll share what this exactly was. The name of this app is Move Care, and it is being developed by a company in Israel or Jerusalem, one of those places. And the data was presented by a French investigator. So what they did was they conducted a randomized trial in 121 patients with lung cancer, advanced disease, and it was also not younger patients. The first question that comes to anybody's mind is like, oh, app savvy is probably somebody who's 21, right? No, these were, at the risk of sounding politically incorrect, no. But these were relatively older patients with advanced disease. They were randomized into 2 separate arms. One arm were given access to this mobile app called Move Care. They had to report weekly self-assessments on 12 different symptoms. And the other arm had regular 3 to 6 month CT scans, the regular standard follow-up as a typical lung cancer patient has to do with their clinicians and their team. What they saw was that at the end of 1 year, patients that were using the app, 79% of these patients were alive, compared to only 46% in the regular standard follow-up arm.
I think Bonnie's been talking about that for 10 years.
Exactly.
Patient empowerment and education.
So what they were basically doing was, through the app, they were communicating weekly with their care team. The app had an inbuilt algorithm. What it was doing was, it was assessing if the symptoms that were entered by the patient were normal, routine, or there was something off. If the algorithm found something off, it instantly pinged the oncologist. The oncologist got on the phone, brought the patient in, and did whatever follow-up needed to be done. And because of this, because of the app, patients had fewer scans, improved quality of life because there was more personalized care, more regular treatment, regular care from their care team. Patients were not waiting till their next appointment to go and see their doctor.
Or that it's too late, they're now more complex.
Right? So what I did was, because I knew I was going to talk to all of you about it, I reached out to this company and I asked them, because right now it's available in France and it's available in Europe. I said, what about our patients here in the US? What about them? When are we launching it in the US? So the French investigator said it's launching in January of 2017. I will be on it and I will share this news with you when it comes to the US. So, these are all interesting developments. Such a simple thing. Imagine just a mobile app where you just have to enter your symptoms weekly and you see such huge differences in overall survival.
Right.
So those are the kinds of themes that emerged, which showed that when patients themselves are deeply involved and engaged in their routine follow-up, in what's happening in their treatment journey, you see improved outcomes.
And how many times, as Bonnie said, if you have a question, ask it.
Exactly.
Don't think that you're going to be bothering someone, or this is just trivial, or this really doesn't sort of mean anything in the grand scheme of things. It does.
It does.
And so we've got to get used to asking those questions and creating that pipeline. And if it isn't an app today, then maybe it's an email system that you have with your physician. And those are the kinds of things that you want to set up in advance to say, this is how I want, this is the level of care and communication that I want to set up.
Absolutely. And be your own advocate. Ask those questions, go there more often, ask about clinical trials, ask about immunotherapies, or ask about anything that comes to your mind. Even if you, say, suppose have a new symptom, ask them about it.
Right. So I think I want to move on to new developments in small cell.
Yes.
That was another area that you talked about.
Yes. So like I touched upon in the beginning of the talk, small cell lung cancer has not seen any developments for the past 30 years, right? What has been the standard of care for what was established 30 years ago is still what's being done. Patients are on platinum doublets, and response times are shorter. Responses are not durable. It isn't where it should be. But at ASCO, there were 2 very interesting results that were presented, and I will share those with you. One of this was something called ROA-T. So ROBA-T is basically an antibody drug conjugate, ADC. What does an ADC mean? An ADC is basically two things. It's an antibody and it's a drug. How does it work? An antibody is something that will take you directly to where you need to go. And it's like a Trojan horse, or you could consider it like a missile, right? So the missile directs you where you need to go, and it's carrying a payload, or it's carrying a warhead that it delivers exactly where it needs to deliver it, right? So that's what an ADC is. So the team at Sloan Kettering developed this ADC against a protein called DLL3. DLL3 is a protein that's expressed on 70% of all small cell lung cancers, right? 70% of these small cells express DLL3. We now have a drug that will specifically go to cells in the body that are expressing DLL3 and kill them. So you have something that is not non-specific like chemotherapy. Chemotherapy kills anything that's dividing and replicating, right? Okay. And that's why your hair go away. Anything that's dividing will get killed with chemotherapy. But with this therapy, it's targeted. It will go only to the small cell lung cancer cells that are expressing this protein DLL3. And it's, this is still early data, I would caution everybody, but it's very promising data. And there are new clinical trials that are accruing patients right now. Mm-hmm. So I strongly urge whoever is a small cell lung cancer patient to consider ROBA-T in their treatment regimen, ask their doctors about it.
So would they need to get retested today, or is it something that they can go back to?
You will need to be tested for the expression of DLL3, whether your tumors express DLL3 or not. And even that usually is part of the clinical trial, so don't do it before you actually have a discussion with your doctor. Have a discussion with your doctor, reach out to the team. The team's at Memorial Sloan Kettering in New York. The physician is Dr. Charlie Rudin. We can connect you with them if you want.
So again,
the connection.
Theme of the night is get reconnected with Danielle and Michelle to anything that you learned tonight, to say, I heard GUNEET talk about this, reconnect me with this particular clinical trial or any more information.
And the trial is accruing right now, so patients can participate. Small cell lung cancer patients can participate on this clinical trial. The second very interesting and impressive data for small cell that came out was immunotherapy combination. So we discussed immunotherapies, CTLA-4 and PD-1, right? The two checkpoints, and combining those. They combined these two for small cell lung cancer patients in the second, third, in the later line settings. This is, patients who've stopped responding to first line therapy, stopped responding to second line, extremely refractory, difficult to treat patients, and they showed responses.
Wow.
And what was seen was that 10% of patients who were on the nivolumab arm, the PD-1 arm, responded, and 20% responses seen in the combination arm. So the combination holds potential benefit. So something for small cell lung cancer patients to consider. There are more details here. If you have questions, please feel free to ask me. And interestingly, these responses were also independent of PD-L1 expression. So it did not matter if your tumor expressed PD-L1, small cell tumor expressed PD-L1 or not, patients responded.
So that's in and of itself.
Right? Two new exciting things. And there's lots of immunotherapy developments happening for small cell lung cancer.
Yeah.
We're seeing all of this happen for non-small cell. There's a lot happening in small cell also in different lines. Upfront, first line, and then second, third line, combinations, monotherapy. So ask your doctors about these clinical trials, how you can participate in them, and not just be on chemotherapy.
So do we have any questions on small cell? I know a couple of people had talked about that. I'm not seeing any. So one of the last themes that we're going to talk about are these biosimilars.
Yes.
So I want to talk about that. Then you're probably going to need to do a little bit of wrap up on the liquid similars, and then I've got some questions.
Okay. So in terms of biosimilars, this is something that excited me a lot, and I wanted to share it with all of you because, this is something I've been waiting for a very long time. So when we talk about, chemical drugs that have a chemical basis, that are chemical compounds, we have generics, right? So there's a drug that is on patent, and when the patent expires, there are several new generics that come up, and you can use them. Those are cheaper, relatively easier to, because you already know what the chemical compound looks like. But what do you do when you have a biologic drug? When I say a biologic drug, I mean antibodies, I mean vaccines, I mean interleukins. These are things that are produced by living organisms, right? If something's being produced by a living organism, it's a drug. It's called a biologic drug. Now, these biologic drugs are extremely difficult to copy, right? Because it's being produced by a living organism. How can you copy that very easily? So you cannot have a generic for an antibody, right? And therefore, all antibodies, like the PD-1 antibodies, nivolumab, pembrolizumab, all immunotherapy drugs are supremely expensive, right? So how can we get this to the masses? How can everybody access drugs like immunotherapy drugs? That's where things like biosimilars come in. So what is a biosimilar? A biosimilar is something that mimics a biologic drug. It's not exactly identical, but it's very similar.
Is it kind of considered the generic?
Kind of.
Kind of.
You know, it's almost disrespectful to call it a generic because it's so difficult to manufacture.
Okay.
Because it is also manufactured by a living organism, and there are very stringent regulatory things that you have to go through. You have to make sure this biosimilar has similar efficacy, it has no toxicity, it is not being recognized by your immune system as a foreign thing. So, you know, it's difficult to create a biosimilar, but things are happening. And at ASCO this year, there was data that was presented on a biosimilar for breast cancer, trastuzumab, which is being used for HER2-positive breast cancer. Great data, and looks like it will probably be approved for breast cancer patients very shortly. So what's happening in the lung cancer space? We all know that bevacizumab or Avastin is used by several patients, and there are biosimilars that are currently in development for bevacizumab, and there are several others that are in the pipeline, new biosimilars for biologic drugs for lung cancer. So it's exciting, it's new things that are happening. How will we benefit? The cost of treatment is going to come down, right? That's how, you know, how we get these therapies to everybody.
Right.
So, you know, I found it very exciting. I thought I should share.
So if I go back to that, then how is that going to be more widely accessible? Because it's not as complicated as the first.
Because it's not going to be, because if there's competition, prices come down.
Okay.
Right? Because if I am the only one, I can demand my market
So that's
price.
the definition of the biosimilar.
So there are several biosimilars that are very similar, have similar activity, have similar, efficacy, are not toxic, are safe. There are so many. So patients have the option of choosing, and price automatically comes down, right, when there's competition.
Right.
Yeah.
And that then drives new discoveries, right? Because everyone's sort of trying to find the new discovery.
Yeah.
So we have about 10 minutes left, and then we've got to do our thank yous and all of that. Was there any questions on biosimilars? We have, yes.
Yes.
Yeah.
What are the dangers involved in it? I see some pretty
Yes.
drastic warnings on the labels. And that.
Yes. And immunotherapies are fraught with several side effects. And like I mentioned earlier, the side effect profile for being on an immunotherapy agent is very different from a chemotherapy agent or a targeted therapy agent. And it's not non-serious. So if you see a symptom, you need to talk to your doctor about it.
You talked about immediately.
And yes, and any kind of symptom that ends with an itis, pneumonitis, colitis, hypophysitis, thyroiditis, all of these different kinds of itises are seen with immunotherapy. There's this very interesting phenomenon that is being seen that was reported also at ASCO about autoimmune diseases being reactivated when somebody went on immunotherapy. So there was cases where lung cancer patients, went on immunotherapy and they, Crohn's disease, ulcerative colitis. Some patients developed rheumatoid arthritis. They did not have this before going on the immunotherapy, but developed these. So immunotherapies can reactivate underlying autoimmune diseases, and it can initiate new autoimmune disease in a patient that goes on immunotherapy. So we need to be careful for these symptoms. We need to watch out for these symptoms. We shouldn't be so ecstatic that we are on immunotherapy and we're responding that we ignore these, because it can potentially be fatal. Because like I said earlier, we are playing with the immune system, right? And it's not, all's not lost. You can go on steroids to manage these symptoms. You can easily manage them, and you can stop therapy for that time, when you are experiencing those symptoms, and then you can restart therapy. And there is some emerging data that shows that stopping therapy for some period of time does not impact efficacy to a huge extent, right? Does that answer your question? Awesome.
Okay, I have 4 very specific questions, so we're going to take a few seconds and try and answer each one of them, because our online viewers are awesome, and they're throwing in questions. Does KRAS move to the brain?
I don't know. But for KRAS, what I do know is KRAS is associated with a higher mutational burden. And KRAS patients need to think about immunotherapies.
Okay.
I don't know about the brain.
Okay. Patient used Tarceva, year 1, another year's passed. I think what they're basically saying is if you moved off of Tarceva onto a second line, could you think about going back to Tarceva?
Yes.
Okay.
And this is very interesting.
I think that's the online question. I wasn't quite sure, but I think that's what they were saying.
So, I'm going to answer this not specifically about Tarceva, but about targeted therapies in general.
Okay.
There are some very interesting case studies that are being presented at meetings like ASCO coming out in the scientific literature, which says that, when you're in a targeted drug and this is your treatment journey. You go on first-line therapy, say suppose Tarceva or Xalkori. You stop responding, you go on second line, for example, Tagrisso or alectinib or ceritinib, depending on what your cancer profile is. What happens is, as you continue through these multiple different lines of therapy, there are times when your cancer becomes again responsive to the first line therapy. And there's been reports where patients...
How would you know that?
Testing.
Testing, okay. So that's what we keep saying, testing.
Yeah. Testing.
Talk about testing.
And, in one report that came out from Alice Shaw's group, she tried, it started with crizotinib, this patient went on brigatinib, lorlatinib, and again, resensitized to crizotinib. So if you go through these multiple lines of therapy like you asked, all's not lost. You can easily go back, your tumors get resensitized, so it does happen. I don't know the frequency at which it happens, but it does happen.
So then there was another question about frequency of testing, whether it be liquid biopsy or molecular testing. So that's what I'm hearing is to be dependent on your personality of your cancer and how it either changes or progresses or stays the same.
Yes, absolutely.
Okay. And then last specific question was Simavax, the Cuba lung cancer drug mentioned at ASCO?
No, I did not see it. And I know that it is being evaluated at Roswell Park. Yes, absolutely. So it's being evaluated at Roswell Park. It is going to enter clinical trials at Roswell Park, but I don't know what exactly is happening right now.
Okay, so that's something we could maybe get more information to our online question about.
Potentially.
Where to send them to get more information.
Yes, Roswell Park.
Okay.
Yeah.
Okay, so I think we've kind of exhausted our online questions, but I want to make sure that everyone in this room has had a chance. I mean, this is amazing dialogue. Can I just say how impressive it is that the level of questions, the level of information, the dialogue that's happening is just amazing. And I congratulate everyone for really digging in and understanding a very complex environment, right? I mean, there was so much conversation about the molecular makeup, the genetics, the new discoveries. And so I think you still, at the end of the day, think, where am I in all of this? Where do I fit into all this? So how do we answer those questions for patients? What do I take away and where do I go? What do I do next?
So what do I do next? I think the first thing is, have you had molecular testing or not, right? If you've established you do not have EGFR, ALK, ROS1, how long ago was that established? Right, so that's because if your disease progresses, it is important, like we discussed, to have another biopsy, to have another testing done, to again test what your cancer now looks like, right? Because like we discussed, cancer mutates, cancer changes over time. It is not going to be the exact same as when you were diagnosed.
Right.
Because of treatment pressure, because of mutations that are constantly happening. So what does your cancer look like today? So it is important for you to have a control, like at least understand what it looks like today. And that can be done through liquid biopsies or traditional tissue biopsies, right? And for you to just know that there are several options for you, right? There's so much hope. When I go to ASCO and I come back with all this, I am so hopeful for where we are at right now, right? Consider things when Bonnie was diagnosed.
Right.
Bonnie did not have access to erlotinib. Bonnie did not have access to immunotherapy. Like, none of these things existed, even liquid biopsies. And look at where we are today, right? For each of these individual slices of the lung cancer pie, we have new targeted treatments that are either approved or are in clinical trials. We have immunotherapy. We have combinations that are happening. So there's a lot of hope, right? So never lose hope and be our own advocate.
Well, I'm going to put you on the spot.
Okay, let's do it.
I'm going to say predictions while we're celebrating and enjoying 2016 ASCO research data. What are you going to see in 2017? What are the things that are really going to jump forward, you think, in this next year?
So I think we will see more data on combinations, what really went through and what did not pan out.
Okay.
You know, we will understand that better. Because right now we are seeing excitement. We are seeing, you know, positive preliminary results. These will completely pan out.
The theories have come forward to something.
These will completely pan out by next year's ASCO. I am hoping that by next year's ASCO we have better biomarkers to identify who responds to these drugs and who does not, right? Because immunotherapies are not inexpensive, right? These are expensive therapies and they have side effects like we discussed. So we need to know beforehand who are these patients who are most likely to respond. And we don't have a way of identifying that right now. We are in the way, on the way there, but we aren't there yet. So I'm hoping that by next year's ASCO, we have some solid biomarkers that we can just go test for and know that, okay, I have this, I will respond to immunotherapy. I am hoping that happens.
And would you say that the patient engagement part of it is to ask about clinical trials?
All the time.
Okay.
And to be your own advocate, to constantly stay on top of things. Do not accept what your doctor told you and just go with it. Question it, read, come to us, ask Michelle. Like, we are here to help.
Right.
Right?
So, and I want to reiterate that. I think I've kind of said it a couple of different times, but we've talked about the 6 different themes that you saw at ASCO, and you have a 19-page summary of what she saw at ASCO. What your walkaway point with tonight is reach out to Danielle and Michelle, your patient advocates, to talk further about this and help you determine language to bring back to your team, your care team, right?
Absolutely.
So, I mean, don't think that we have to dissect or digest all of this information tonight and determine what tomorrow then brings is our next phase in our journey. We have a place to go here to have that conversation. And you're obviously accessible, and everybody's going to call you tomorrow as well.
Okay, absolutely. Bring it on.
I have a feeling we're going to have a long night of wine and food. I wish for our online viewers we could somehow send the food and wine over the airwaves, like a scratch and sniff or something, so that you guys can enjoy the food and wine that we have here. As well. So we have just like 1 minute left. Anything burning, anything before I start on announcements and bore everyone completely with our final announcements? Everybody's good? Great night, right?
I will again
go.
push you folks to go through this because it will probably explain things better than I did.
Oh, I think you were phenomenal. Can we give GUNEET an amazing round of applause? So awesome. And can I just remind everyone, GUNEET is part of the Adario lung cancer team. So she is here on site, available, and can take a lot of your complex conversations that you have with physicians and say, tell me what this really meant.
Yes.
Right?
Absolutely.
So, I mean,
Anytime.
Now 2 announcements. Education like this, patient conversations like this can't exist without the supporters. So I want to say thank you to Penn TV for always being there for us to live stream and to get this conversation global. And then I want to also make sure that I thank Lilly, Celgene, Merck, Novartis, Genentech, and Astellas. Of course, you saw all of them at ASCO and had great conversations. Katie, you probably had some information on events. We have September San Francisco walk. What date is that?
Oh,
there we go.
We have Hollywood, Florida, September 18th. We have San Francisco, September 25th, and we have some teams here in the audience with us. Philadelphia, October 2nd. Spartanburg, November 5th. That's a new event for us. And then on the endurance side, we have the San Francisco Marathon, the Disney Marathon coming up. We have the gala event November 12th. And then if anybody is interested in doing their own fundraiser, we encourage you to reach out to us because we'd love to partner with you on that as well. So you could reach out to our team and we would love to work with you guys. So lots of fun stuff coming up, and we hope to see a lot of your faces there and your family and friends. So.
And Katie, thank you for all the work that you and the fund development team, or actually the entire team, do, because without the dollars raised, right, we couldn't be doing the patient education and making sure that we reach everyone who wants this information can have it.
Absolutely.
Available free of charge and right in your own living room and in your own pocket and on an app.
And through this.
And through this. So you also have a patient survey or a survey that you want to announce to make sure that everyone has access to and fills out, right?
Yes. So we've been talking about targeted therapies, and the foundation is looking at a specific molecular marker called ROS1. What we've been doing is we are trying to change the conversation in terms of looking at cancer not from its anatomic origin, like, I have lung cancer. Instead of saying that, saying I have ROS1 cancer, basically talking about the oncogene that's driving your cancer. So what we are doing is we've launched a global research study where we're getting patients from different kinds of cancers together into this one group online through the foundation. All of these patients have ROS1 alterations. There are lung cancer patients, melanoma, GBM, cholangiocarcinoma patients, multiple different kinds of cancer patients coming together, all connected by having the same oncogenic driver. So we're trying to understand these ROS1 cancers better through this research initiative that we are leading through the foundation with these patients being their own advocates, these patients wanting to drive research in this space. So together with these patients, we are leading this effort, and we've launched a global survey. Through the survey, what we're trying to understand is what is driving these ROS1 cancers, right? What's happening in them? So that, and we want you all to fill that survey out. It's on our website.
Okay, and that's going to be also on the banner. So I have 30 seconds left until we're offline for our online viewers. I want to say that the next living room, please tune in August 16th. The conversation will be around payers and coverage of medical costs. A lot of what you talked about tonight all will wrap around whether or not it's covered and how you navigate that system. So very important topic. So I've got 5 seconds left. Thank you to everyone online. Please continue to ask your questions. We'll get them to you, and everyone here, stay. All right, I think we did it. Right? I think we did it.